For the next half hour, I'm going to talk to Eric Dishman, who's the founder and general manager of Intel's Health Research and Innovation Group. And I looked at your biog, and you've got a strange biog, and that is because you marry two things that don't often go together, and that is a sociological way of looking at healthcare, plus you know the technological stuff. Most people either know one or the other, and it don't quite work, you know. How do those two ways of looking at healthcare illuminate what you do?
It is a strange thing to be a social scientist at Intel. I'm a communications scholar by training. My team at Intel has the largest social science group in the industry, and we actually are in constant tension with kind of traditional Intel because, you know, for so much of Intel's history, it was about sort of make microprocessors faster and
Sure.
you know, meant money as a result of it. And it's clear that those days are not going to be here forever. So a lot of our work is really rooted in trying to understand the needs of people first, and in this case in healthcare, and then come back and say, what kind of innovations can solve those problems?
So what do you actually do then? You go to the scientists and say, look, that ain't the way people operate. That's not what they think.
I mean, the simplest example I can give you is when I was hired at Intel, I'd been working for Paul Allen's think tank, Interval Research, and Intel called me and said, hey, we want you to come to Intel and come study people who aren't into microprocessors or into computers. And so I said, all right. So we went and actually studied, for the very first study, it was basically people who were into entertainment and television but had no interest in PCs, weren't aware of what PCs might do. This whole world of TiVo didn't exist yet. MP3 players didn't exist. So the whole study was called The Future of Fun. And we went and lived with 300 households in 9 countries, trying to just understand their needs and think about what the future of digital entertainment would be based on understanding their needs. But what was interesting in the study is anybody over the age of 40 or 50 in these homes would quite frankly look at us and say, I don't need another way to watch 1,000 television channels. And they would proceed to tell us a story about managing their own chronic condition, or more often, taking care of their aging parent. And so what started out as the future of fun, you know, or I say digital entertainment, became a study of dementia, quite frankly. And if you listen to what people's concerns were, and it took me 3 years to convince Intel to pay attention to what consumers were telling us, we started focusing on health and wellness, using the same entertainment infrastructure, but not the future of fun anymore.
But how does that help Intel? I mean, you know, I can see the interest of all that, but how does it figure into that company?
We launched a new business group about 2 years ago called the Digital Health Group that was founded upon this initial research. We have 2 threads to that business. One is traditional healthcare IT. So how do we accelerate Wi-Fi and wireless and compute clusters and other kinds of things in the sort of traditional healthcare? But the most disruptive business is focused on personal health. How do you move healthcare to the home? How do you help with early detection, prevention, behavior change? Because at the end of the day, I mean, I titled this little section, we've got to shift from mainframe healthcare to personal healthcare. It is disruptive technologies that are probably our only chance for actually being able to pay the healthcare bills in the future. And Intel wants to be a part of that. We want to sell platforms, software, services, and capabilities into that emerging personal health marketplace.
I've stopped understanding you. What do you mean in plain English?
We've got to move the detection of disease from hospital to home. Simple example. We're doing a pilot right now with people with Parkinson's disease. We went and studied 60 households dealing with Parkinson's for 6 months. When we went with these patients to that medical mainframe, right, this hospital on a hill where you're time sharing these big expensive systems with everyone else, they would have their 15-minute exam with their physician, many of whom were not trained to understand the needs of seniors or Parkinson's. Their blood pressure would be outrageous because of trying to park at that medical mainframe.
Sure.
And we would do a few tests on them and then send them home and say, change your levodopa, the drug for Parkinson's, based on that 15-minute exam. This is the state of the art. This is what we do for Parkinson's patients. All we've done in this case, and we're a research pilot now, is we've taken the guts of a PC, some of the classic tests that are done for Parkinson's, a finger tapping test where you do your fingers like this on a little MIDI keyboard, 2 arcade buttons, look like big Pac-Man arcade buttons, and you're doing reaction time and motion time tests. A speech test where you tell stories about pictures that you see on the screen. And the ah test where you go ah as loud and as long as you can. And we're looking at changes in voice and in motion that are indicative of progression through Parkinson's, and titrating your medications based on how you're doing that day, not your 15-minute exam that you have with your doctor.
So if you were a Parkinson's patient, you would do that test, the tapping test or whatever, every day or every week or whatever it is, and that would be fed to the healthcare mainframe, as you call it, the hospital, as I call it?
Well, it's fed to multiple places. So in the first phase of the research, and I should make it clear, this is not a product yet, this is research prototypes. In the first phase, we do not show the patients themselves the data. But I can tell you what they've been doing is they've been calling their neighbor or their spouse over with a stopwatch to record how they're doing, because they actually want to know how they're doing, and they actually want to see if there's a positive therapeutic effect of doing these exercises more frequently. So right now, yes, that data goes back to the medical mainframe, but you want to feed it back to the person themselves. And in fact, every study that we're doing with people with Alzheimer's, with seniors with Alzheimer's, we're feeding the data back to themselves so they can change their behavior, so they can be aware of what's happening with their disease, so they can change their economic planning based on what's happening with their disease. If we don't close the loop to the person themselves, then we're just going to make healthcare more expensive.
Which brings me to the point. I mean, the economics of healthcare
is perverse.
Is a and is a nightmare. You know, whatever country you go to, it don't work, but it's got to work. So is what you're doing basically finding ways of mechanizing healthcare? And I don't mean that in a derogatory sense at all.
Well, to a degree. I would say that most of, if you look at the United States, and we were talking about research funding, if you look at where innovation funding is going in the United States for healthcare right now, about 95% of it is spent on making physicians more efficient, electronic health records and all of that. And that's important, and Intel's working on those kinds of things. But that's not going to get us out of this mess, because you basically, we just got the latest figures in the US, $1.9 trillion for the US healthcare bill 2 years ago. We're going to double that to $4 trillion over the next decade. So if you want to know what it looks like a decade from now, we're going to spend $4 trillion or 20% of GDP. We're going to double the number of seniors in the United States who are in retirement, and we're going to double the number of people in the workforce who are doing caregiving, right? That's what it's going to look like for 10 years from now. Who in here is actually doing caregiving for an aging parent now? Raise your hand. All right. I was late to this conference because my father fell and hurt his hip last night, so that's why I didn't come last night. Those numbers that you just raised your hand are going to double or triple. Throwing more money at making doctors who there aren't enough of at this point to make them more efficient is not the end of the problem.
Sure.
If you don't do early detection, if you don't do prevention, if you don't do behavior change and use PCs and cell phones and digital entertainment equipment, all of which is here and starting to be interconnected for doing those health and wellness kinds of things, we're not going to get out of this kind of mainframe healthcare crisis that we're in.
Let me repeat a question I asked earlier, and that is, in 10 years' time or 20 years' time, let's say, what are you working on that we're going to say, wow, I'm really glad they did that?
Home health platforms that will, I hope it's not wow, I hope it's ho-hum 10 years from now, that we're using home health platforms to more proactively manage our own health and wellness. And that means everything. Well, a simple example that we're doing right now with seniors in a nursing home is using a little simple wireless pedometer that can go into their belt or on their wrist, and it's feeding that information back to their television, their TV, or their cell phone. It gives them an idea of the number of steps they've taken that day, and more importantly, this was what was the key, an aggregate total of how all of the other, mostly women in these facilities, are doing on that hallway, right? With a goal of saying, we have 100,000 steps everybody in our hallway wants to get to this month, right? Simple example, technology that's here today of how do you sort of change behavior using everyday electronics, everyday computing, that will have a positive health outcome over time. So by the time 10 years from now, I hope that we're using PCs, cell phones, standalone home health appliances to do a wide range of health and wellness services on top of that.
How does it fit into the way of the Intel business model, if you like, for want of a less pompous phrase? Do you go to them and say, this is what people want, this is where society's going, we can make money out of this, but you've got to come on board and you've got to come up with the gizmos that do it, or how does it operate?
Yeah, I mean, initially, Intel, when we started doing this work, everyone assumed it was being funded out of the charitable foundation, out of the Robert Noyce Foundation or the Gordon Moore Foundation or the Andy Grove Foundation. This is funded out of the business growth part of the company. It takes a while to get that through, but then the numbers speak for themselves. I mean, we just basically looked at it and said, 600 million people over the age of 60 today on the planet, and innovation largely doesn't pay attention to them, right? Innovation is pretty much a youth culture, teenagers and new ways of doing youth culture. Those numbers double to 1.2 billion by 2025, and then 2 billion plus in 2050. So you can take that swag and sort of say, wow, that's a huge market opportunity. At the same time, if you come from the ground up and you look at the number of units ever sold for any kind of home health telemedicine is less than 60,000 units, not interesting to Intel's business, right? So huge need from top down and demographic numbers, but installed base of home health type platforms unbelievably small. Why is that? What can we do to sort of break through so that we could get the kinds of millions of sales that Intel wants? Well, it's a range of things, right? One is let's attract attention to the space of getting companies to pay attention to the needs of seniors. And in fact, I can talk about work that we've done to do that nationally and internationally. This is an imagination problem more than anything. Second is how do we accelerate R&D funding of outcome studies and proof points that prove that these technologies work, just like drug trials, right? You don't want to throw a bunch of technologies at some Alzheimer's patients and hope that they work. You've got to prove them, right? Sure. And the third is really driving standards so that all of that stuff that we already have in our everyday lives, our cell phones, our iPods, our PCs, can start to communicate with each other in some secure and unique ways so that you can share healthcare data and coaching content and other kinds of things across them. Those three things are all the kinds of things that Intel can do to try to help bring scale.
You were going to mention the first of them, the consciousness thing, I think.
Yeah, that's still where we are. That's phase one. So it was funny, when I started my huge lab at Intel, it was myself and one engineer, right? So I tried for 2 years. I edited together a video of all these families of people saying, I need help taking care of my aging parents. I finally sent it to Andy Grove with my resignation letter. He was chairman at the time, and Craig Barrett was CEO. And I said, Intel's not paying attention to healthcare. This is crazy. I'm leaving. I'm going somewhere else. Wait. So they gave me a huge lab of one person. We started studying the needs of people with Alzheimer's. We built a simple sensor network prototype in the home that helped somebody with Alzheimer's get dressed and fix tea for themselves in the morning.
What's a sensor network?
Little wireless. I brought one. I got strip searched this morning in the airport. We should come back to that story in a second. I actually really did. My government strip searched me this morning. This is the only prototype I could bring because they actually took the wearable heart monitoring that I was wearing when I went through off of me. So these are little tiny sensors that we're using to look at changes in gait, so they can be put onto a belt, looking at changes in gait to try to prevent falls before they happen. We've been using them with people with Alzheimer's to help look at how much social contact or how much physical activity that they're getting. These were wirelessly connected and sending data back to a PC or a home health device. Right. That's a sensor network. So in this case, networks of these tiny, inexpensive sensors that we're using to track and capture data in the real world, not that 15-minute exam with your doctor for the first time ever. We built this prototype, very simple prototype that tried to walk you through the steps of making tea or fixing a drink for yourself, because most of the people who have dementia become dehydrated because they literally forget that they're not getting food or getting beverage on time. And all of a sudden, one press story about that got picked up. And suddenly there were about 400 or 500. Now again, I'm buried in the bowels of Intel. There's two of us. Within 3 weeks, I had an Excel spreadsheet of 5,000 names of every technology company you can think of, the Santa Fe Institute, people from Park, saying, how the hell did you get Intel to talk about seniors? Not a very sexy topic. And how did you convince Intel to let you pilot some technologies because we were so afraid of liability? That was 5 years ago. We formed a not-for-profit called CAST, the Center for Aging Services Technologies, that now has 500 tech companies, universities, and long-term care providers in the United States trying to figure out how do we accelerate R&D, how do we accelerate commercialization of these kinds of solutions.
And that came from, what, somebody very high up spotting one cutting in a newspaper?
One cutting in the news. I mean, it's like using the press to get your own management to pay attention to what you're doing, right? I mean, it's back to the blogging thing. If blogging had been around, I would have used blogging. I mean, and it's mostly that, I'll be honest with you, Intel is a primarily male culture. I was in meetings with executives at Intel, a bunch of guys.
Who don't do the care.
Who don't do the care, and they would say, well, I don't think this is an interesting opportunity for us. So I would, in two incidences, I actually had them pick up the phone and call their wife and say, do you want something like this? And we had prototypes at this point that we showed them. Consistently, this is innovation for older people, and this is innovation for women. These are not traditional areas that technology companies pay attention to.
Why are you so passionate about it?
When I was 16, I became a caregiver for my grandmother with Alzheimer's and for my parents who were dealing with that. So much so that I didn't have time to get my driver's license till I turned 18. I mean, I didn't even think about getting my driver's license, right? The American rite of passage, getting your driver's license, it wasn't even of consideration because there was no time to think about it because of the devastating effects that had. And then the other is that I have a numerous kidney problems myself that were supposed to kill me 19 years ago. And the vast majority of people that I do patient advocacy for are in their 70s. Most of the people with my disease are in their 70s. So I'm sitting in waiting rooms with 70-year-olds, hearing their stories, hearing their needs, and understanding what's going on.
So I'm guessing now you got a technological brain, but all this human stuff was happening around you.
Yes.
And that's how the marriage happened.
I mean, we took engineers with us into the homes of people with Alzheimer's, and they couldn't stop innovating, right? They had just never seen these problems before. They're like, people aren't able to put a jacket on because they don't understand buttons, right? Or in the first pilot we ever did with Alzheimer's patients was really because they were so afraid of answering the phone or the front door that they went into sort of social exile because the name lookup table in their brain wasn't working any longer. You brought engineers to see that, and they would say, oh my God, we could build this kind of caller ID on steroids system that helps them know this is who's at the front door or this is who's on the phone, and that's exactly what we built, right? So the moment you bring the anthropologists and the engineers together and you take them out in the world, not letting them study the disease through a microscope or through statistics, but out in the world, innovation starts to happen. And then the trick is choosing which problems to focus on and building them robust enough to test them for real, making sure this is real science, not just a bunch of gadgets thrown out there, and making sure that if you have a claim about early detection, that we're doing an early detection trial with 500 households of 80-year-olds right now. That's going to take 5 years for us to even know whether or not we can use these sensor networks to detect the onset of Alzheimer's. That's hard to get intel to be patient about, right? We do planning cycles quarter by quarter. I'm now asking for funding for 5 years and saying suspend disbelief. 5 years from now, half of those 580-year-olds will have Alzheimer's, and we'll be able to retroactively go back and look at all this data to see what gave us a window into the disease.
Where do the money people come into this? How do you determine which roads you go down and which you don't, or whatever?
We're taking multiple paths. I mean, we talk about money with the people that we study, first of all, right? I mean, when I go do this in Washington, D.C., the politicians love to throw 2 hand grenades into the debate to stop the debate. One is the who pays question, and the other is the sort of big brother privacy question. Both of them are real concerns, and they're part of the research. When you go out and sort of study people, whether it's doctors who are caring for the Parkinson's patient, the family member, or the Parkinson's patients themselves, you address those issues. We're going down 2 paths. Some of it is saying, we're doing a lot of work in Ireland and in the UK now. In fact, we just opened a huge lab in Ireland to test these technologies in Ireland. In that path, the government is the major payer, and there's a much better chance that they're going to reimburse for these systems because you don't have quite the fragmentation or the perversity that you have in the United States. You still have perversity, but it's not
different problems.
Different kind of problems and perversity. We're also working on things that would be direct to consumer, right? You're looking at those half of the women in the American workforce who are trying to make this decision about, do I keep working, do I retire early to care for my mother? And they're facing suddenly putting a loved one into an institutional setting that's going to cost at least $5,000 a month, maybe $8,000 a month. If $1,000 of technology can help keep that person in their own home for a month longer, a year longer than it pays for itself. So direct-to-pay models where you're looking at substitutions compared to what they're going to pay out of pocket anyway. And by the way, most Americans assume that Medicare will cover it, and it doesn't, right? Or models where payers, insurance plans, governments, or employers pay for them as well.
You mentioned it earlier. Where does the privacy thing fit into it? My father's got Parkinson's, and half the stuff you mentioned, all the stuff you mentioned, I think, wow, if that was available, that would be fabulous. But there would be an issue if very personal information about him was being made available around the institution where he is, or anybody who's driving by with Wi-Fi or whatever. How do you get around those problems?
You design for them. And what I mean, well, let me contextualize it for you. First of all, we have now studied 1,000 households over the last 4 years. And studied means lived with multiple times of the year and interviewed, right? In 20 countries. Almost always, the seniors or the older people themselves are like, let me make the choices about the trade-offs of deciding who gets the data, right? Their children are like, big brother, big brother, big brother, right? What we found is that privacy is like an opinion. Everybody has their own. So you go into one house with the Alzheimer's pilot, and we had this, little social health diagram that shows a solar system with the senior at the center and all the people they interact with, and it updates based on how often they're interacting with those people, so they can know who are they forgetting and who's still in their social network. We've got some families who are like, I don't want to share that data with anybody. The next family says, I want to share that data with my son and my daughter, but not my other son. And you have to have another family that says, I'll share this data live on the internet, right? I don't care. Oh. So you have to design the system so that it can be built securely, but then flexibly, so that a senior with Alzheimer's can make choices about who gets the data, but doesn't have to be a network administrator to achieve it. So it's a huge interface design challenge, but that's what we're doing. The other thing I would say to you is there's a man in our Alzheimer's study who had incontinence. Here's something we probably don't talk about enough in the future interview conference. Incontinence. He said to me, I've got somebody changing my diaper daily. Do you think I'm going to care whether or not I'm sharing a little bit of data about whether I'm getting social interaction or not?
Sure, right. Sure. So
I don't want to downplay those issues, right? But sometimes the press and sometimes politicians throw these simplistic notions of privacy into the debate, and it stops innovation, as opposed to saying, let's make privacy be part of the innovation and not stop innovation as a result of it.
Let's get the answer first and then work out how we can make that answer practical.
Yes, and make payment and make privacy be part of the research question, not something that gets tacked on to the end.
I'm watching the clock here.
Tragically.
Yeah, tragically, absolutely.
Our time
absolutely.
is running out.
No,
How symbolic.
I don't think there's a healthcare, on the big question, I don't think there's a healthcare system, a way of doing these things on the planet which works. The British system is on demand, universal. If you're ill, you get treatment, it's free to you. Yeah. The American system is very, very different. Both have huge problems. Does your work illuminate what might be a sensible way of doing things?
I don't have any easy answers. I've read like the 20 latest books on everyone's sort of problems of solving the healthcare crisis, and what none of them get to really is that what's universal across most of these healthcare systems is we have a have problem, take pill paradigm, right? We wait until you have a problem, and I'm not anti-drug. I'm living here today because I've taken some pharmaceuticals that have kept me alive. It's just our notion of what constitutes care has sort of been relegated to a pill. Right, and that's the only answer. We don't prescribe behavior change, and we don't reimburse for behavior change. We don't develop innovation that's going to drive behavior change when that's going to be the end of the cost of it. I think there's some interesting work that we're doing in South Korea, in Uganda, in Ireland, not the UK, where we've kind of said, let's start from scratch and say, if you design a healthcare system that's unit of analysis for care is the patient themselves, their medical professionals, and their families, and design systems that connect those three, right? Don't just make doctors more efficient, but actually design a care network around those three and let that be your unit of analysis and start from the ground up with that. I think that's the direction that we have to go. But I would be lying to you if I'd say, the gravity of the conversation always returns back to the sexy new piece of MRI equipment that the hospital's going to get. The gravity is so focused on that medical mainframe and how we make that better, that it's really difficult to pull the conversation back and say, the medical mainframe is broken, it will not scale as you double and triple the number of seniors on the planet. What's some other model? And I think that's the other model we need to sort of be clear about and design for.
Eric Dishman, thank you for your wisdom.
Thanks for letting me be here. Great to be here.
Thank you very much.